So, thank you so much for that introduction. And it's such a pleasure to be here to talk about something that has been so close to my heart for so many years. So, I started my career as a nurse in New York City, where I got to do and see firsthand the gaps in care. I worked as a home health nurse for many years, along with my critical care career. And these are some of the people that I saw when I go into the homes. And these pictures kind of show you what you see on the surface, right? So you see on the first top picture there a doctor or a provider going into an apartment, and you see a doctor kneeling down next to the elderly lady. And all these pictures are great. You see a patient in the home being seen. And I will say that these pictures really show you just the tip of the iceberg of what home health, home based primary care is. So I'll tell you a little story. A patient of mine that I saw, one of my first patients in 2020, um, who had just recently suffered a stroke, um, a massive stroke with left sided weakness. This patient has other medical conditions, including diabetes, hypertension, didn't really have a lot of family. And I was introduced through the community resources, the case manager. The patient was essentially bedbound, couldn't leave the house to go for his appointments. They were discharged back home or slash an assisted living kind of setting, but with very little care coordination, not really sure what medications to stop or not. So when I was contacted, I could tell you that some of these pictures of what you see here, uh, even though they're great and you see providers smiling and everyone looks comfortable, sometimes there's just so much, what would I say, other things that you would see, like depression, worry, anxiety, stress, a lot of other psychosocial things that are part of the social determinants of health that affect each person. And this is just not the patient, this is also for the family. So, fast forward, getting involved with this patient, my job as the provider or home based provider is to try to piece together how I could help this patient not go back within 30 days after discharge. So, this includes medication management, care coordination, getting home health in to make sure that there's nurses going in there to make sure that he doesn't have wounds, that he's taking his medications, a social worker who's managing his finances for him after a stroke, who's his legal guardian, does he have one? There's just so many aspects of home based primary care. Another case I would give you is someone who's suffering from dementia, uh, really debilitating dementia, where family is essentially frustrated. The patient is in and out of the hospital. They have to work, they have their own family, and they're at their wits' end and they don't know what the next step is. They don't know what to do. They want to keep their loved one at home. They don't want to put them in a nursing home. They don't want to put them in an assisted living. So they're stuck. They don't know what to do. There's no advanced directives. There's no goals of care conversation. What would this person want? Would they want to go back to the hospital? Would they want to be kept alive, regardless of the circumstances? So these are just some of the things, very critical things that we in home-based primary care deal with. And this population really are the higher utilizers of healthcare because they are very sick, they're medically complex, and the only way they can get care most of the time is by going into the hospital by dialing 911. So home-based primary care really is a path to high quality, low cost care. So I'll go and talk about the benefits of home-based primary care. So like I talked to you before, really what it does is address, that I'm not sure if you've heard of this term, the quadruple aim of effective primary care. What we aim for is to make sure that these patients have improved patient experience, meaning that they have that highly engaged interaction with their primary care provider. They're not waiting weeks and weeks to get into an appointment. They don't have that time to wait. What is the communication like? Who's checking their blood pressure? Do they have someone that they can trust that's really coming and engaging with them. So patient engagement, right? Provider experience. So I'm sure you've heard about provider burnout, where they're, seeing 20, 30 patients in a day and having all these other administrative burden to deal with on top of that. Population health, right? So making sure that we're addressing the whole population, not just one patient at a time. How can we reduce all these chronic conditions? How can we make sure that these patients are staying out of the hospital? And then costs, lowering the cost of care. High utilizers, they're high medical utilizers, they're going into the ER only when they really need to, when their exacerbation, when their disease is exacerbated, their heart failure is worse, their diabetes is worse, is the only time that they go to the hospital. So what we do in home-based primary care is to make sure that we are helping disabled, aging patients to stay at home while being actively involved in their own treatment. And if they can't, we try to support the family, the guardian, the assisted living, and so on. We aim to alleviate the burden experienced by many caregivers. I cannot tell you how much stress this causes to family when you have a loved one that you want to care for, but you don't have the resources, or you don't have the support to kind of know what's the next step. How do I make sure that my mom or my dad or my sister is getting high quality care, is getting exactly what their wishes are? How do we allow providers to gain a better, more holistic understanding of a patient's health day to day? So, how do we make sure that we are using all the tools, data, like remote patient monitoring, for example, so that we can closely monitor our patient's health, right? Some patients' comments that we see here that really make us know that we are on the right path. Somebody says, I would be in the ER if you were not here today, right? So somebody's suffering from shortness of breath. We look at their remote patient monitoring, the data that we see that either their weights are going up. So because of that, we go into the home, we fix their medications. Patient is feeling better, they stay out of the hospital. I didn't know these resources were available. Some people don't even know what home-based primary care is. They sometimes we get confused with home health, and that's another big thing. So I, just want to share with you, home-based primary care is primary care in the home. So your annual wellness exams, your vaccinations, um, let's see, you're sick, you don't feel well, that kind of thing. Goals of care conversations. If you just want to consult to determine, what do I want, what I don't want if in the event something happens to me and I'm really, really sick, we can have those conversations so that somebody doesn't call 911 and then you go to the hospital and all these things that you don't want happen to you end up happening to you. Somebody says, I'm relieved that you know about my medical care and that you come to my home. So, one of the things that we strive for is to make sure that there are no silos in healthcare, right? So, making sure that the systems are talking to each other. And we'll talk more about that later in this conversation. So I wanted to showcase this slide because it is basically the bread and butter of home-based primary care. Chronic care management really is what we do on a daily basis with our patients. So we are more proactive, if you will, rather than reactive. We try to make sure that we're seeing these patients as often as possible, providing personalized attention, frequent communication with patients. So, ideally, in a perfect world, we would want to have, that engagement with a nurse, for example, who is calling this patients ahead of time and saying, hey, I see that your weights are going up. Are you taking your medication? Or do just, patient education, talking to the family, talking to the patients, working as a team with the provider to make sure that the patient is getting the care that they need. So we, again, utilizing technology, telehealth, remote patient monitoring, where we could monitor their diabetes and their weights and their blood pressure. Super, super important with this population. And then transitions of care. So again, this is where the technology comes in, where we are working with hospital systems to make sure that if the patient does end up in the hospital, we know right away. We get a patient report or a summary saying this patient just got discharged. You need to see this patient within 48 hours. We get the report, we get into the patient's home right away. So these are just different parts of chronic care management. It involves behavioral health, partnering with occupational therapists, physical therapists. When we start to see weakness or some signs of debilitating disease, we can get other multidisciplinary teams involved. So I'll talk a little bit about challenges of home-based primary care. Like I said, there is a lot that goes into caring for these patients. Most of the time, they're medically complex. They need a lot of attention, not just in person, but non face to face time, a lot of care coordination involved. And this is often time not reimbursed by their insurance, like Medicare or Medicaid and what have you. So that time is really the bread and butter of home-based primary care. So, doing medication reconciliation, making sure that they have all the durable medical equipment that they have. Do they need a walker? Do they need a wheelchair? Um, do you need to go talk to their family members about things that are happening in between visits? Goals of care conversations, that kind of thing takes a lot of time. And often the reimbursement model we have, which is fee for service, meaning you're sick, I come see you. Otherwise, I don't see you for 3 months. Or, the patient just came out of the hospital, I'll go see you then. So there's all usually a lot of gap in between. So if there's not that care coordination piece in there, it just home-based primary care doesn't really work. Um, so these payments do not sufficiently cover the cost of taking care of these patients. Travel time associated with house calls, of course, there's nothing really you can do about that. That is the challenge. So you can't see 20, 30 patients a day. Most of the time, these patients max maybe if you are in maybe an assisted living facility, maybe you can see 10 because they're all in one place, right? But if you're driving from Muldoon to downtown or wherever, that can take a lot more time. So smaller caseload. So essentially, that face-to-face fee-for-service model is the main challenge for us in home-based primary care. So the path to high quality care. So just from my experience over the years, for someone like me who sees all of this need, and I've been, doing a lot of work on my own to see what I can do. So I've talked to health insurance companies to see if we can renegotiate our contracts to, really show this is the value. It's so important that we get paid for this so that we can expand. And what do I mean by expanding? Expanding means, getting nurses on our team, getting social workers. It's so important to have a social worker because there's a lot of social needs. Do they need meals on wheels? Do they need even even with coordinating goals of care conversations? Getting the right people involved. It's such a huge help if you have that. A nutritionist. Right now, we do have some of those resources and we reach across the aisle. And I'll share with you some of the people that we work with in the community um, to try to make sure that we are all communicating with each other so that we can help these patients. So, successful partnerships like, health organizations. Number one, like the health information exchange is a huge way of breaking down those silos. It's really frustrating when you see a patient 1 week and then by the time you go back to see them another time, you realize they've been in the hospital for a couple of weeks you didn't even know. So those silos can be very difficult. So it's really important that systems talk to each other so that you can get information easily. So the other thing is maybe partnering with larger systems for better contractual agreements. I mean, I'm not sure if that even is a thing, but in my mind, I think of it as, big, larger organizations have more bargaining power, if you will, so that there's a way you could work with them, try to, show them that this is a need. It'll help their organization reduce their numbers, their hospitalizations, the number of wounds that are coming in, that kind of thing, so that we're helping them and then they can help us in return. And then educating the public. It's a huge, big deal. The public needs to know that these services are out there so that they're not dialing 911 and just going to the hospital. So I would say that those are the biggest way for this to be completely successful, right? It takes a village to take care of these people. So here are just a list of community resources that have been very, very helpful in helping us out. We've got home health agencies, multiple. There's so many of them. Nonprofit like Hospice of Anchorage, they've been really great about communicating with us and saying, "Hey, there's this patient that is ill, could you go in and see them?" And a lot of the patients that are we get referrals from, a lot of the times, they have a single payer like Medicare, and so it's the challenge there is making sure that they get this service, but also that they're completely covered. They're not left with a bill that really they shouldn't be responsible for, really, because they need those services. Alzheimer's Resource of Alaska is another one. Assisted living facilities throughout Anchorage, we've worked with in the past. Pharmacies, that was a big one. Local health department and pharmacies in getting the COVID vaccines during the pandemic. Local hospitals, care managers, discharge planners, and care coordinators in the community. Um, and that's pretty much all I have to say, really. I hope that this presentation enlightens you more. You know more about what home-based primary care is, and I look forward to answering questions. Thank you.
Thank you so much, Ade. A big round of applause, either on camera or virtually. Wow, what an excellent overview of what you've built and why you've built it. I've put in the chat a couple of times about these partnerships. It seems like you've gone a long way with creating them, but I would like to just open up the floor and see if there's anybody who initially has a question. Marco?
Hi, yes, absolutely. Great presentation, and I can't express enough how important it is what you guys do and are doing for these patients that really it makes more sense for them to be at home and to be cared for at home. So my questions are going to be more on the technology side, because I have a couple of ideas and maybe just to share back. But you mentioned, remote patient monitoring, you mentioned telehealth. Are those technologies that you're partnering with, or maybe a mix of partnerships? And are you curating your own solutions, so to speak?
Thank you, Marco. That's a great question. So, we did partner with a couple of technology solution companies. They're separate. One is for chronic care management, and then the other one is for remote patient monitoring. So, those systems, those technology solutions are integrated with our electronic medical record system. So, it's great because it just pulls the data from that machine. For example, if we're monitoring blood pressure, it'll pull their information, the data, and then we can just follow that in our EMR.
Okay.
Yeah.
Okay. And the reason why I'm asking is because uh, part of my work is monitoring what's going on with the government agencies from perspective of non-dilutive funding. And there's a lot of activity right now on caring for seniors. And there's a new consortium that was just opened up under the MTech agency, and supported by the Department of Defense, but it's not for just defense or military, it's also for civilians. And this new consortium is called Senior Healthcare Innovation Consortium, that's focused on elderly patients being cared for at home or at other locations outside of the hospital, and technology, digital health, wearables, monitoring. So if it's interesting for you to learn more about sort of any agency funding for what you guys are doing, I can pass that on by email. I'm certainly monitoring that consortium. And specifically, when you mentioned fee for service, remote patient monitoring, telehealth, CPT, there's a bunch of CPT codes that I've sort of been monitoring and tracking over the last 2 years, specifically for remote patient monitoring. I'll send that your way if it's helpful. And then the last thing before I hand it off to my colleagues here, you mentioned the from the hospital to the home, the discharge, that certainly there's that continuum of care that you're providing through home-based primary care. What if the other way around, sort of now you're caring for them at home and they needed to be, they needed to go back to the clinic or the hospital, Do you do that transition as well?
Absolutely. So, of course, we always try to make sure that they stay out of the hospital. But in the event that they do need to go to the
Mhm.
hospital, there are very strict criteria. In fact, one of the things we try to do is, especially if they're in assisted living facilities, um, they they know that, okay, this patient is under home-based primary care. So there are different criterias like
Mhm.
shortness of breath, chest pain, things that are like emergent that they have to go to the hospital for. But we always encourage them to kind of call us and let us know. And then we can kind of triage and say, okay, yep, you know what, let's go in and see this. I think this is something we can probably deal with rather than sending them to the hospital.
Great. Yeah,
Won-
I'll share with you offline some of the resources if it's helpful. And again, great presentation. Appreciate all that you guys are doing.
Thank
Thank
you
you.
so much.
And Marco, it's always wonderful to have your expertise here. So
Thank
I
you.
can definitely do an email introduction.
That'll be
And
great. Yes.
while we have time, we have two final questions. So Carolyn Hogan would like to know if you're enrolled as a Medicaid provider, and Carol Howarth would like to know if you're planning to scale up. So if you would take a minute and answer both those questions.
Sure. Yes. So we are a Medicare and a Medicaid. So we do bill Medicare and Medicaid. A lot of our patients tend to have Medicare as primary because one of the big, like I said before, our bread and butter is chronic care management, which Medicare reimburses for. If the patient has a primary insurance of Medicaid, unfortunately, we cannot bill for chronic care management. So that presents as a challenge. We still offer our services to Medicaid patients. We just can't bill for that chronic care management piece.
And then as far as scaling, I know you want to grow
Yeah.
your business.
Yes. So in terms of scaling, it'll be great to be able to see more patients. Right now, we're kind of capped is the amount of patients that we have. Right, we had one extra provider, but unfortunately, that provider moved out of state. So um, getting more providers on our team, getting especially nurses, being able to compensate them very well and make sure that they are, doing the best job, doing the because they are going to be doing the chronic care management, calling the patients, sometimes maybe even making home visits to check in on patients. So I would love to scale in that way and getting a social worker, a behavioral health provider. Behavioral health is such a huge part of home-based primary care. So if we can scale in that way, that'll be great.
So we do have time for a couple of more questions if anybody else has any.
Hi, this was a great presentation, and I missed the very beginning. My name is Siobhan Cunningham, and I am a social worker, but essentially my secret sauce is that I've literally worked in every aspect of healthcare except for home health in the sense of insurance and reimbursement and all of that. So one of the questions I have, because of kind of what I do, is figure out how people find their clients. How are you finding your clients?
Is it Shaban?
Siobhan, yes.
Siobhan, nice to meet you, Siobhan.
Nice to meet you.
So it really is from, I mean, nowadays I think more from the hospital, because sometimes the hospital is so full, the case managers are more inclined to give us a call and say, hey, we have this patient. A patient doesn't have to be homebound, but they tend to go for patients that really have a difficult time leaving their home for appointments. So we will get calls from case managers. We will get calls from assisted living facilities if they have a patient where or a client in the home that it's hard for them to get transported out or bed bound, something like that. So we would get from their care coordinators as well in the community. Sometimes patients find us on Google and they'll call us and say, hey, my mom and my dad really needs a lot of help. So we will get self referrals as well. And as I mentioned, Hospice of Anchorage, we've worked with before, Alzheimer's Resource. We've had, I think, one or two from there. So yeah,
Great. Thank you.
you're welcome.
Wonderful. And we're closing in on our time. I think, Doug, did you have one final question?
Yeah. Apologies if I missed it, but when you say shift from fee for service to value-based payment model, is that essentially a subscription model? Could you elaborate?
Yeah, Douglas, that's a great question. So, value-based care has been on the move for some time, really, is where, eventually Medicare or insurance companies in general will start to shift from fee for service to value-based payment system. And it's not new. There's a lot of actually home-based primary care programs that are already doing this in other states in the country. So I think that it'll be beneficial for those kind of contracts. However, for a smaller um, business like me, it's kind of challenging because you really have to meet a certain criteria for those programs. A lot of those incentive-based, value-based programs, the data, you have to have the data to show what you're doing, which is why I really look forward to really partnering with larger organizations because I think we would get there quicker. Um, but yeah, it's not a subscription base where, they pay a certain fee or anything. This is still through insurance, if that makes sense. Hopefully that answers your question.
I'm Googling away already.
You'll find lots of information there, but yes.
Thank you.
You're welcome.
So we typically wrap up at 1:30, so we have about 1 minute left. I'm happy to stay on. Are there any final questions that anybody has? No? Well, then I just want to say a huge thank you to you, Ade. We are so grateful for the work that you're doing in the community, and I can see from the participation and the interest that people really understand the value that you're providing. And so I will do some follow-up emails and make some connections. And then I encourage everyone, if you'd like to learn more about what Ade is doing, please reach out to me and I'll make sure you make a connection. And Carol Howarth will have our last comment. She says St. Elias might be interested in might be an interesting hospital to connect with. They have some challenges with discharge. Awesome. Great tip. Thank you very much.
Thank you, Carol. Yes, I definitely have gotten some referrals from there before, but yes, you are definitely correct about that.